four hormones, the aldosterone, antidiuretic hormone, cortisol, and thyroxine, are essential for maintaining sodium and water homeostasis. Now, what I will do in this next few minutes is to present four cases. But before I move on to cases, I will spend a couple of minutes on the basics of sodium and water homeostasis. Now, when we say the plasma sodium is low, the first thing that we need to look at is the serum osmolality. So the physiology is that the plasma sodium is the main determinant of the plasma osmolality. So by and large, when the serum sodium is low, the serum osmolality is low. That is the rule. So in a true hyponatremia, the first thing that you need to look at is the serum osmolality, which will be low. So it is hypotonic hyponatremia and the low serum osmolality. This is the rule. However, there are two exceptions to this rule where the hyponatremia is pseudo, it is falsely low. And these two conditions are associated with a normal serum osmolality or even a high serum osmolality. So conditions like very high serum proteins, very high lipids, they are responsible for a spuriously low measurement of serum sodium, and here the osmolality is normal. Now when you have other unmeasured solutes like high glucose, mannitol, alcohol, these are situations where the serum osmolality is high and the sodium is spuriously low. So the message of this case, of this particular slide is, number one, measure the serum osmolality. Number two, rule out these disorders. Now the next thing is, in clinical practice, hyponatremia mostly is associated with an excess of ADH secretion. Now how do we know whether clinically that ADH is present or not? So when antidiuretic hormone is present, there is water reabsorption, there is an impaired free water clearance, and therefore the urinary osmolality will be high. So presence of a high urinary osmolality in a hyponatremia says that ADH is present, and what is important for us is to know whether this ADH excretion, whether this ADH is appropriate or inappropriate. So this is the second clue that we need to see in a case of hyponatremia. And the third important thing is check the volume status. So based on the volume status, if the total body water and the sodium are lost, it is called hypovolemic hyponatremia, which can either be due to renal or extrarenal losses, and most common cause of the renal losses is the use of diuretics. And there could be hypervolemic hyponatremia. Here there is more of water retention when compared to sodium, and then you find that this is seen in heart failure and cirrhosis. So today's my focus would be on euvolemic hyponatremia, and the most common cause of euvolemic hyponatremia is the syndrome of inappropriate antidiuresis. Causes are many, which we all know, starting from central nervous system disease, malignancies, pulmonary disease, HIV, drugs, and so on. Two important endocrine conditions that produce euvolemic hyponatremia are hypothyroidism and glucocorticoid deficiency. Now, classification of hyponatremia. So this particular slide is very important because this forms the basis of treatment of hyponatremia. So there are four ways in which we can classify hyponatremia based on biochemical value, mild, moderate, severe, based on the etiology, hypervolemic, euvolemic, and hypovolemic, based on symptoms, mild, moderate, severe, and based on the acuity of onset. So the treatment depends on these four parameters. Now with this background, I have four cases to present. So the first case is 74-year-old lady is admitted to the emergency with collapse, vomiting, diarrhea, and hypotension. She has been receiving steroid injections into the knee joint every 6 months for the last 2 years. She uses topical steroid for psoriasis with psoriatic arthritis. And if you see her labs, sodium is 129 milliequivalents per liter, so it is low. The plasma osmolality is 272, it is low, and the urinary sodium is 107 milliequivalents per liter, so it is high. Now, based on the history, because the patient was using steroids and stopped, a random serum cortisol was less than 1 microgram per deciliter, the ACTH of 6 picogram per ml, suggesting that this is a case of secondary adrenal insufficiency. So she received IV hydrocortisone 50 milligrams followed by 200 milligrams of infusion for 24 hours along with IV fluids. So the diagnosis of this case is an acute glucocorticoid deficiency and hyponatremia. So the deficiency, this is a secondary adrenal insufficiency. We all know that cortisol regulates ADH secretion. So in the absence of cortisol, there is no inhibition of the ADH secretion, and that leads to fluid retention. In primary adrenal insufficiency, remember it is an aldosterone deficiency that also contributes to hyponatremia. So the second case is a 72-year-old male diagnosed with small cell carcinoma of the lung. He is asymptomatic, he is euvolemic. His serum sodium is 127 millimoles per liter low, potassium normal, creatinine normal, urine osmolality is high, suggesting that there is ADH secretion, and the urine sodium also is high. His cortisol and thyroid functions are normal. So before we say somebody has inappropriate ADH secretion, you have to rule out hypocortisolism and hypothyroidism. So all these being normal, the diagnosis of this case is syndrome of inappropriate antidiuresis. So this particular patient is asymptomatic, and then so he was managed with fluid restriction followed by 7.5 milligrams of tolvaptan to maintain the serum sodium in the normal range. Now the case 3 is a 43-year-old male who underwent uneventful transsphenoidal surgery for non-functioning pituitary macroadenoma. He was discharged on hydrocortisone 15 milligrams in the morning and 5 milligrams in the afternoon with a plan to measure the serum cortisol 1 week after surgery. So usually patients are discharged in a couple of days with this particular prescription. And on the post-operative 6th day, the patient returns because he feels unwell, he has nausea and headache. He is compliant with hydrocortisone. He is taking it regularly, and his vital signs, blood pressure were normal. His serum sodium is 129 milliequivalents per liter. So this is a case of transient syndrome of inappropriate antidiuresis, and the patient responded to hypotonic saline. Now what is a word about hyponatremia following cellular surgery? It is very common, with a very high prevalence of CIAD. It is transient, usually occurs 1 week after surgery, starts at 1 week, may last till the end of 2 weeks. Mild cases respond to fluid restriction, severe cases need hypertonic saline, may occur even without the immediate post-operative DI or the typical triphasic response. So we are all aware of this particular diagram of showing the triphasic response, what happens to the ADH secretion after cellular surgery. But practically this is very rare. What we usually see is the isolated second phase. So the two important messages from this case are, number one, to restriction of fluids to at least 1 liter in the first week following cellular surgery is helpful. And the second thing is to monitor the sodium till the end of second week. And these are the two important rules that we need to keep in mind. Well, this is again the diagram from Professor Verbalis' paper. You can see that the left one shows the typical triphasic response where, you know, there is a total injury to the stalk, and you can find 1, 2, 3 showing which are responsible for the triphasic response. But by and large, what is more common is the isolated second phase. Now the last case is a 49-year-old male, healthy male, admitted with subarachnoid hemorrhage. His CT scan showed extensive subarachnoid hemorrhage with a 6 mm PCA aneurysm. He underwent coil embolization and he was monitored in ICU for vasospasm and for volume status. On day 4 to 6, his sodium levels started dropping from 132, then 128. He appeared hypovolemic. There's a drop in the systolic blood pressure from 120 to 100. The labs showed he had hypouricemia, increased hematocrit, normal creatinine, normal TSH, normal cortisol. Then the urine sodium, urine osmolality were elevated. So this is a picture which is similar to the CIAD, which is called the cerebral salt wasting syndrome, which is rare. And then the difference between CIAD and the cerebral salt wasting syndrome is the presence of hypovolemia here when compared to the euvolemic status in CIAD. Now, it's very difficult to treat hyponatremia in this particular case. He was given normal saline, didn't respond. Then he was given hypertonic saline followed by fludrocortisone to correct the refractory hyponatremia. Now, intracranial disease and hyponatremia, what are the etiologies? There are 4 important causes. Not everything is CIAD. So it can be a syndrome of inappropriate antidiuresis. It can be cerebral salt wasting syndrome. It can be acute glucocorticoid deficiency. An injury to the hypothalamo-pituitary axis can produce a hypovolemic hyponatremia because of acute glucocorticoid deficiency. And sometimes fluid overload because of over-judicious administration of fluids can also produce hypervolemic hyponatremia. So what is important here is that we need a rational approach to look at the cause of hyponatremia in intracranial disease. Now the key differences between the syndrome of inappropriate antidiuresis and cerebral salt wasting syndrome in intracranial disease, as I already said, the cerebral salt wasting syndrome is a hypovolemic state where you have hypotension, the urine volume may be more than when you look at the CVP will be low, suggesting that this is a hypovolemic state. Now, this is just a slide about the cerebral salt wasting syndrome where you can see the etiology of this particular syndrome, though it was said to be due to a decrease in the sympathetic tone and a decrease in the aldosterone and an increase in the natriuretic peptide that are more responsible for natriuresis. But however, by and large, many studies have shown that this is more of a mixed etiology. Now finally, management of hyponatremia. As I already said, these are the 4 important parameters. One is the symptoms. The second is the duration. Third is the biochemical severity. And 4th is the volume status. So these are these will decide the management, and most important tests are the urinary sodium and the urinary osmolality. Now, treatment of hyponatremia. Severe hyponatremia is an emergency where treatment the managing hyponatremia is of paramount importance first, followed by looking for the cause. So you give 100 cc of bolus of 3% saline over 10 minutes, then look at the sodium. If there is a rise, that's fine. Otherwise, it can be repeated up to 3 times. And the goal is urgent correction of the serum sodium 4 to 6 millimoles per liter to prevent brain herniation and neurological damage. Now, moderate symptoms begin with a prompt diagnosis. Remove offending medications and other factors contributing to hyponatremia. Look at the cause and treat accordingly. Consider a single IV infusion of 150 cc of 3% normal hypertonic saline over 20 minutes. Now this is my last slide. So the take home message is history and physical examination are important to know the etiology of hyponatremia. Establish true hyponatremia. Look at urine osmolality, volume status and urine sodium. Rule out hypothyroidism and glucocorticoid deficiency before establishing CIAD. And severe symptomatic hyponatremia is an emergency, needs to be treated with 3% hypertonic saline 150 ml infusion to increase the sodium by at least 5 millimoles per liter. Chronic hyponatremia, use cause-specific therapies. Now with this few words, I thank you all for listening.